Welcome to We Need to Talk, the podcast that features a series of conversations aimed at shedding light on issues surrounding women. I am your host, Gleniva Hodge, and this is a space where women can discuss the issues we've been forced to barely whisper. As women, we know we need to talk means things are at a point where they must be addressed now. So join us as we tackle conversations that are necessary, even if they make you slightly uncomfortable. Hi, and welcome back to another episode of We Need to Talk. This week, we are going to be jumping right in to discussing fibroids. This episode is going to be informative. It's going to be a little bit entertaining, maybe. And I am pleased to welcome in studio with me Dr. John, and I will allow her to introduce herself in just a bit. So go and grab your drinks, grab a snack, settle in, because we need to talk. Dr. John, welcome to We Need to Talk.
Thank you. I'm pleased to be here. The fact that you said we're going to be entertaining people, though, I'm looking forward to see how that actually happens.
How that happens, how we entertain.
Yeah.
How about we start with what you call me?
Oh, no.
You know, because I didn't introduce myself. By now,
Yeah.
my listeners know my name. I am Gleniva.
Yes.
But Dr. John does not call me Gleniva.
No.
So
On purpose. On purpose, I actually say Gleniva.
yes,
I think it sounds lovely that way. Gleniva. It's really nice. So
it's been a while. I've gotten used to it. When I hear Gleniva, I know it's Dr. John. I don't have to wonder who it is that's calling me, because we've known each other for a few years.
yeah, we go way back. You know.
We
Yes,
do.
we do.
So if you hear her say Gleniva throughout this episode, she really means Gleniva. But
Yes. Forgive me.
but by now that is her way of referring to me, and I know it's our thing. It's now our thing.
It is. It definitely is.
Yeah. So welcome.
Thank you. Thank you for having me. In terms of introducing myself, my name is Wanda John. I'm an OBGYN in terms of training and in terms of qualifications. I am, however, in terms of my passion, I am basically a person who loves to see people do well and who loves to see people be well. I'm a mother of 3, husband of 1. But you have to put that in. And I'm here to discuss uterine fibroids tonight. Quick disclaimer, I do work at the Department of Health Services, but I am not here on their behalf. So what I say is purely my opinion and not necessarily reflecting those of the department. So just putting that out there just in case.
Certainly. So yes, let's just jump right into it. Uterine fibroids.
Yes.
What are they?
Okay, that is a question that has plagued people for a while, because we already know uterine fibroids are abnormal growths. You use the word tumor and people automatically think cancer, but uterine fibroids are not cancer. Okay, but they're abnormal growths in the uterus, the female uterus. Growths that occur in the middle portion of the uterus, because you have the endometrium, which is the inner lining, then you have the muscle, which is where the fibroids grow, the myometrium, and then you have this, what we call the serosa, which is almost like the skin of the uterus, if you want to put it that way, but it's the thinner outer layer of the uterus. Fibroids grow mainly from the muscle lining. When they grow from the muscle lining, they can, of course, protrude into the inner portion of the uterus, and they can also protrude to the outer part of the uterus as well. But the fibers that grow are mainly muscle fibers at the beginning.
Okay. So they usually begin as muscle fibroids.
They are.
Okay,
from
they
muscle,
are.
Yeah,
okay.
From the muscle layer of the uterus. Yes.
Okay.
Yes.
Fibroids, growing up, heard my mom talking about fibroids, maybe my aunts. it seems to affect so many women.
Very common, unfortunately.
Why?
Very common, and also depending on who you are, they might be more common around you, because it has been shown that among women of African descent, Black women, it's more common. So for whatever reason, whether it's genetics, whether it's because of whatever influences, hormonal influences we have that propensity more to have fibroids than, let's say, some of our Caucasian or other counterparts. Yeah.
Okay.
And we still don't know the reason.
And we still don't know
Let me
why.
just put that out there, because if you go and you check even the latest publications, we know what affects fibroids. We know what would possibly cause fibroids to grow, but we don't know why they actually happen.
Okay. So what would cause them to grow?
What would cause them to grow? All right. So fibroids generally grow because of stimulation by hormones. All right.
Okay.
So even, for example, in pregnancy, when you have this wonderful hormonal experience taking place for your baby to grow, the uterus is growing, and fibroids, especially in the first and more so in the second trimester, you could have fibroids. If they're already existing, then they could actually get bigger. Right. Now, there are a lot of other thoughts in relation to whether it's dietary or other habits. For example, if you have a high estrogenic or high estrogen prone type diet or foods, okay, then you can actually be more prone to it. But a lot of it is genetic. A lot of it, if your mother had fibroids, your aunt had fibroids, there's a high possibility that you could also have fibroids. What controls it would more be how much stimulation they get during your lifetime.
Okay.
And it's generally during your reproductive years, because that is when you are more estrogen prone. So hyperestrogenic, meaning more estrogen, more growth generally. Okay. Lower estrogen, for example, in menopause, less growth. So that's why a lot of people, they have fibroids, and then when they reach menopause, the fibroids begin to shrink, because the amount of estrogen that they have circulating actually decreases. So they don't usually grow. If we see fibroids growing during that menopausal period, go see a doctor. Then you know something may be wrong. Okay, something else might be going on.
Something else.
And you'd have to look into that.
So persons with fibroids, and I think thinking back to a friend of mine, and she had a fibroid, and when she was pregnant, the belly was all distorted because there's baby and then there's fibroid.
Right.
And,
sharing space.
They're both sharing spaces, and she shared the picture of what it looked like after. It was this huge mass. But for her, I think it robbed her of that nice, pretty pregnancy bump. Okay. Because it was a little bit distorted, and as women, we tend to feel a bit conscious about our bodies when it's not looking the way that we think it should. But other than through pregnancy, when they tend to grow, can we live with them? How does that work?
Well, the thing is, a lot of people have fibroids and have no idea. You can have fibroids and have no symptoms whatsoever. You can have fibroids walking down the road and have no idea, because one, they may be small, they may not affect your quality of life. For example, whether you have heavy periods or not, you have fibroids, for example, that are not protruding into that inner layer. Sometimes it doesn't affect your periods.
Okay.
And if you have no pain, because these are the primary symptoms that people come with. They either have abnormal bleeding, they either have pain, or they could also have a situation where they feel something, a mass, something protruding, or they feel a heaviness as well too, pelvic weight. All right, and that is what sends them to the doctor. But there are states before that where you have no idea. Unless you do an ultrasound or you do, palpation, whether it's a pelvic exam or something, you may not actually notice that the uterus has grown in size until it has grown significantly in size. So there are women who have fibroids and have no idea until they start presenting with symptoms. So you can live with fibroids, yes, because if it affects your quality of life, that is when we try to take steps. And that is sort of the rule when it comes to fibroids, because of the fact that they're not cancer, and they may not necessarily cause any sort of changes in terms of your overall quality of life. We act when there's change. We act when, for example, the pain is excruciating. We act when the bleeding causes you to reach the point where you are, anemic. Your blood count is really low. You're bleeding so much that you can't go without changing your pads every hour, that sort of thing. So you can't work as effectively. You can't function as effectively as you would want to as a woman. And that is sometimes when, or that is usually when we would have to do something. And mind you, we can do other things other than the last ditch or last stage, I guess you could say, treatments beforehand. But some persons are not always willing to take the steps to actually do anything, because for them it has become their norm. And for them, sometimes they have a certain amount of fear to actually go and check it out, because there are women who would say, for example, I don't want to know. Which is strange to some. I don't want to know. It could be nothing, it could be something, I don't want to know. And then you have others, at the slightest thing, they would go and check. And then you'd find out, and then you have a plan towards how to actually deal with it. I prefer the ones who check. I don't want to know might have you coming in with your blood count at 4 or 5, and then your heart rate is high because your heart is trying to pump enough blood since you're so low to all of your organs. So it's better to know, but be at peace in the sense that once it's a fibroid, it's something that is treatable, it's something that is common, and it's not the end of the world.
Okay. Let's speak a little bit more about some of those
treatments,
symptoms. Back to the symptoms,
okay, right?
Because a lot of times we may just think that something is normal.
Yes.
You may have a heavier flow during your period. You may just think, well, that's just what that is. You may have pain and you think, well, that's just usual menstrual pain.
Right. That exists too.
Right.
That's the thing, yeah.
And so it's at what point, what symptoms really should we be looking for that would trigger us to go, so I need to get this checked out?
Right. So generally, in terms of the bleeding, if you're changing pads often during the day, some persons change up to like 2-3 pads and they're okay. But if you're changing 4, 5, 6, 7 or more pads in a day, even if fibroids are not the reason, you should probably check to see what's going on. Okay? A lot of times you can have what we call abnormal uterine bleeding or dysfunctional uterine bleeding that is not necessarily linked to a specific cause. But if it's a cause that you can find and treat, then you can actually make the quality of life for that person a little better. The pain, depending on where the fibroid is, whether or not it's what we call degenerating, it's losing some of its blood supply and it's not too happy about it, so it's, makes your life miserable as a result. And so when that starts to degenerate, sometimes you can have a lot of pain. And when the pain is of such that it makes you unable to function the way that you would normally function, then obviously that's something that we'd need to look into. Mass, feeling that, that heaviness, feeling that size, that weight, because you could assume it's fibroids, but it could be something else. So it's always good to check, because there are other things that are not fibroids that are in fact dangerous, that can in fact be life-changing in the sense that, you'd have to do treatments and surgeries immediately, that sort of thing. So you'd want to know for sure, is it a fibroid or is it, let's say, for example, an ovary that's too big? If an ovary is too big, for example, and it's not a simple situation, then, and depending on your age, all of that, then yeah, there are other studies that have to be done. So it's best to know. That's the idea. It's best to know. And also, women should be having their checkups.
Right.
Okay? Whether or not you're having a pap smear or whatever, every year you should at least have a checkup with your gynecologist just to make sure that everything is going the way that it should.
Yeah. You mentioned ovaries, and I've shared with my...
Oh, you have?
I have.
Oh, okay.
I have shared with my viewers, a little bit of my story and a little bit of my history.
Okay.
And Dr. John, and I'll state this. Dr. John is my doctor, and if I trust her with my life, I can trust her with the information that we put out there. Because one of the things that is very important to me is really putting information out there that's trustworthy, that persons can go, this is a trustworthy source. Obviously, it's not meant to replace a doctor's visit, but it is important to me that the information that is placed out there is factual.
Yes.
And so I've trusted Dr. John with my life several times, you know, to put me under, to do what needed to be done. And so just wanted to share that, since I have previously shared a little bit about my oophorectomy and everything else that has happened inside of there.
Okay, but I actually wasn't speaking about you in that case.
I know,
yes,
but
just to be clear,
that's
yes.
fine. But I wanted to
because
to put that out
unfortunately,
there.
even in, for example, later years, when things like ovarian cancer are more prevalent, or then there are women who might have a mass and assume it's a fibroid, and it really isn't. So when you do scans, then you realize, okay, this is an ovary, and it's not looking good. Okay. Not looking simple, not looking like something that you take it out and then that's the end of it. All right. So that's why I say some persons, they sometimes have a mass, they assume it's fibroids, and it's not. And so then, of course, you'd have to.
Yeah. So you feel a mass, you go and get checked.
Yeah.
You have heavy bleeding to the point where you need to change 4, 5, 6 pads a day, go and get checked.
I don't say 3 because some persons, as soon as they see a little bit, they change. So,
you
know, but especially if you're having full pads, if you're having like 3 very full pads, maybe, you know, you should start to be a little concerned. But in terms of having to necessarily do something, then anything more than that is really,
definitely
really too much. Even 3, depending on how full they are, you know, it's something to look into. Some persons, because of stress, they do have heavier periods 1 month over the other. But if this is happening to you consistently, then yeah, something might be going on.
Okay. So you spoke about where fibroids are in the muscle part of the uterus.
Yes, myometrium.
And you say sometimes they can protrude.
They protrude into
the uterus.
Inside. And those are the ones that bleed the most. The ones that protrude to the inside bleed the most. And so that is where, because they increase. All right, so the uterus is like, I'm trying to think of like something that it looks like. Let's say you have a fruit that has an inside, like a flat inside. I can't think of a fruit right now, but
almost like
something,
a papaya?
Like a papaya could work, yes.
Okay.
I was trying not to say avocado, but that's what came to me first.
Okay.
So let's say you have a papaya, you do pawpaw.
Yeah, papaya, yes.
Right? And without the seeds necessarily. But you have, let's say you have a fibroid pushing in there, then normally you might just have a cavity like this. Something's pushing in and it's causing like a mass effect on the inside, then the amount of surface area that bleeds is going to increase. So whereas before just this would bleed, then you have that and whatever was up here, then more. So it distorts the cavity and you have more areas that would bleed. And when you have more areas that would bleed, you have heavier bleeding.
Okay.
That's one of the things that it does. So it can increase the amount of bleeding you have. And that's the main reason why. So it goes on the inside. If it's not there, then you may only have pain, or you may only have that mass effect.
Okay.
When they're on the outside, more on the outside, then they can actually press against other organs, and that is where we get things like kidneys being affected because of the pressure on the ureter. So then it kind of backs up your urine a bit, and you get a bit of dilatation there. So fibroids, depending on the size and depending on where they are, there are a lot of different symptoms that you can get, and to different degrees.
So those that usually don't affect us, the ones that we probably don't even know
about,
that they're there,
right?
What would that size be?
Ooh, it depends on the person. Yeah, it depends on the person. It depends on the location, the precise location. Because if you have it very close to the cervix, you could have discomfort, vaginal discomfort. If you have it to the top, you may not have a clue until it's maybe about 6 or 7 or even 8 centimeters, let's say. But once, depending on where it is, it could cause more pressure or not. Normal, no symptoms, maybe 2-3 centimeters. You may not
Okay.
have anything.
Okay.
You may not have even known that you have fibroids
Okay.
if it's not on the inside. Because even that, if it's nearer to the inside, then you can have an increase in your bleeding, even with that size. 3-4 centimeters, you can have an increase. But normal, okay, normal is probably not the right word.
Yeah, relative.
But you know,
Yes.
depending on where it is, you may not have a clue
Mhm.
until it has actually reached above that.
Okay.
And that's an estimate, of course, because it varies. If you're very thin, for example, you might feel that mass effect earlier than somebody who's not.
Okay.
So there's no one line.
It varies.
It's just like health in general. It's very much, you know, personal and individual.
Okay. For those fibroids that protrude into the uterus itself, usually the only normal thing to be in the uterus is a baby. Yeah, a fetus.
Yes.
Yes.
That's true. That's
usually
true.
the only normal thing in there is a fetus.
Right. We do IUDs as well, but I guess that might not be normal.
But necessary sometimes.
True.
Okay, so other than the implanted IUD, the normal thing for the body to have in there would be a fetus.
Yes.
If a fibroid protrudes into there,
right,
does the body think that it's a fetus at any point? Does it give symptoms of? Is that possible?
Not usually. If you see, for example, an increase in your abdominal girth, you might think, okay, I may be pregnant, but once you do the test, you realize you're not. Right?
Okay.
The body itself does not think you're pregnant, except with hormonal changes, usually. Okay. So once the pregnancy hormone is released, then your body thinks, oh yes, we're pregnant, let's do something about it, you know, like that, usually. But in terms of the person thinking that they might be pregnant, if they notice a growth in size or something, then they might believe that they are. Okay.
So nausea, that kind of stuff?
Not usually.
No.
Okay. Those are not frequent symptoms with fibroids. Okay. Where you can have a problem, let's say, and this is if you have something affecting the bladder, the ureter, you may be more prone to, let's say, infections like urinary tract infections, UTIs, that can produce nausea. But that's pretty rare. It's not necessarily a symptom of the fibroid itself, of having a fibroid itself. Okay.
Just making sure. This is a learning lesson
for
me.
Yes.
for a lot of us.
And I don't know everything. That's right. Yeah, go ahead.
But really just trying to take it all in. And you said estrogen causes the fibroids are increased to grow.
They love estrogen. It's like sugar to them, if you understand what I mean.
Okay.
And that's a weird analogy, but they love it. It's
so they feed on it.
Essentially, yes. It stimulates growth of the fibroid. So when you have low estrogen, in fact, some of the treatments that we use nowadays actually decrease your estrogen levels in order to have the fibroid shrink. Things like that. And some of the foods that we've noticed, for example, high soy, for example, in your diet. Soy is considered an estrogenic food. It's a phytoestrogen, I think it's called, or rather something after you eat the soy, it's converted into a pseudo type estrogen situation. Well, I probably have to look that up.
So like soybeans and soy milk.
High soy content is actually estrogenic in nature. Yeah, it's said that mainly what we use on this side of the world, because there's some cultures like in the Middle East who may use it, but they ferment the soy first. So from my understanding, once it's fermented soy, it doesn't have that effect. However, what we have, soybean oil, all these other things, they're not. So you can actually have that effect as well.
Okay. So other than soy, is there anything else, any types of foods that...
Okay, so red meat has been associated with increase.
Red meat, so steaks, beef, mutton.
I believe you can have things in moderation.
In moderation.
Okay. But our traditional Western diet is not a moderation diet.
Curry goat, you know.
It's not a moderation
mutton.
diet. It's not a moderation diet. So
Mhm.
we have to therefore think about actual portion sizes, and perhaps depending on how bad it is with us, we might just be able to leave things out
That's
completely.
altogether.
Yeah.
Okay. Okay. So red meat, soy.
Yes. Okay. So this is a bit controversial.
Okay.
Because in terms of some dairy, and the reason why some dairy can actually cause issues, some persons liken it to having the animals getting hormones and these sort of things to increase their milk supply and so on. I don't have personal proof of this, but this is one of the things that is floating around that could actually be not helping the situation as well too.
Okay.
If you have your cow in your backyard, we could probably just study to see if that would also be a problem. But generally, milk production across the world has been tainted with. Yeah.
Okay. So those are some things that persons can
avoid. Yes.
Is it preventative as well? To cut back on, so to reduce your red meat intake or your soy intake. Mm-hmm. Would that be preventative?
Well, what we found in general in medicine is that even if you have a genetic predisposition, there are things that you can do to help to prevent. It does not mean that you would definitely not, but perhaps it might not be as bad as if you were engaging in whatever activities or diets that would not be beneficial or would, that's actually something that is a recommendation usually. When someone is high risk for something, we try to say, okay, like if you have a high risk for diabetes, don't like sugar, try to stay away as much as possible, things like that. If you have a strong family history of high blood pressure, for example, don't like salt, train your children from young even, you have a and it's not a pure hereditary situation with a lot of these chronic diseases, but there is a lot of association, family association, when it comes to these diseases. So it's not like you are in this family, so you'll definitely get it. Okay. There seem to be other factors that we're not aware of, or sometimes even environmental factors that could affect.
I was thinking, because you're in the family, but you tend to be eating the same foods.
Yes.
And the same factors that may have affected one person would affect another that isn't necessarily genetic.
Yeah, and that is where you create your habits. From young, we have the habit of, or we get the habit in terms of what we like to eat, what we will continue to eat all our lives unless we make some drastic decisions and changes. So it's important to try and change whatever habits we have gotten from young and see, if we can prevent those things from
carrying on. It leads back to the conversation that we had with our guest previously, Mrs. Roberta Rose Collins, and she's a health and lifestyle, health and a board certified health coach. I think that's what it is. And we spoke about really getting our children into a more healthier lifestyle so that this comes on. And hopefully we should soon have a health and nutrition expert on in an upcoming episode. So we're going to be speaking with someone about what our diets should look like.
Good.
So these conversations are not happening in silo. We're not just speaking about one thing and we're not giving, the support behind it. So we've spoken about the symptoms. We don't speak about, and we've spoken about what can feed it. The estrogen, which is like the sugar to it, it feeds it, loves it. Treatment.
Right.
What can that look like?
So treatment can vary depending on who we're dealing with. Every person is different. Every situation is different. Every uterus is different too. Okay. So if we're looking, for example, at someone who is still planning to have children, because we have the uterus to reproduce, right? As well as have periods and all that other stuff. So we have the uterus for a reason. If you are still using it, to put it bluntly, if you're still using it and you want to keep it, then some treatments are not for you.
Okay.
All right. If you have finished using it and you're maybe have reached a certain age and you're sure, I'm not going to have any more children, I don't need to go through this, or you're not necessarily close to menopause too, that's another consideration, then you have a lot more possibilities, a lot more treatments available. Okay, so let me try and organize this in a way that would be ordered. Okay, and not going all over the place. So you have your surgical and you have your non-surgical.
Okay.
And even in the surgical, you have different types. So generally, the aim of the surgical would be either to take out the fibroids alone or to take out the uterus on a whole.
That's a hysterectomy.
Yes, uterus on a whole is hysterectomy, and the fibroids alone would be a myomectomy.
Okay.
Okay. So you're taking out just the myomas, which is another name for fibroids.
Okay.
So it's a myomectomy. And if you're taking out the uterus, then that's a hysterectomy.
Okay.
So if you plan to have more children, the hysterectomy is not for you.
Because you need
your uterus, right?
Because the uterus is what houses
the baby.
Yes.
So if you plan to have more babies, that's not for you. The thing is, though, and we always say this as doctors, especially when the case is particularly complex, one of the possible complications of a myomectomy is a hysterectomy. Yes. So you're doing a myomectomy, and let's say things go awry. May not happen frequently, but you may end up having to do a hysterectomy depending on how things go. So that's something that you always have to tell people. So that's surgical. Now, there are other ways you could have laparoscopic and hysteroscopic. There's a lot more there.
Okay.
We'll leave that for now. But there's surgery.
Okay.
What you take out and how you take it out depends a lot of times on the person and sometimes even where you are, what you have available. Then there's non-surgical. Sorry.
No. Let's stick with the surgical just a little bit. So, surgical, we know you can do
fibroids alone.
Everything.
Whole uterus. Yes.
Whole uterus.
And depending on the age, maybe even the ovaries as well, just to
there you go.
Make sure that you also don't have that possibility of ovarian cancer later on in life too. Because if you've already finished using your ovaries as well, going with them might save you some hassle later on.
So, again, we're learning here. We take out we take out the uterus. We leave the ovaries. Can you still have a period?
No. You will have hormonal changes because a lot of your hormonal changes are at the level of your ovaries.
But if we leave the ovaries,
you'll still be a young woman. Depending on the age, you'll still be the age that you are. No menopause.
So
immediate menopause, surgical menopause.
Okay, so you keep the ovaries, but you take out the uterus.
No
periods, but you don't go into menopause.
Right. You go into menopause when it's your time to go into menopause. With the uterus, remember we said the lining, that is what bleeds when you have your period.
Right.
So you don't have that lining, you do not have a period. Which is why it is one of the treatments for persons who have very heavy bleeding. You get rid of what bleeds. And when you get rid of what bleeds, then that problem has essentially disappeared.
Okay. Science has never been my strong suit.
That's okay.
Far from. But TikTok.
TikTok is a strong suit.
TikTok. There are things that, TikTok has...
Adjusting myself.
Illustrated. The ovaries, I want to paint a picture for persons who may not know what inside looks like.
Okay.
So you have your papa or your avocado.
Okay.
That's your uterus.
Let me tell you how I've done it most simply, I think. Okay. So a person standing up, right? This is a basketball player, female basketball player, of course.
Yes.
And she has a ball in one hand, a ball in the other, and she has them held out like this, right? So each ball is an ovary, okay? The arms are fallopian tubes.
I'm glad you went there.
Yeah.
Are the balls attached to the...
Yes and no.
So there
are ligaments that they have in common, but it's not that it's literally attached.
Okay.
necessarily. They have things around them that are attached, and so they're kept in close proximity. But you wouldn't normally see them always attached. And interestingly, you find that there are people who have done videos as well too, where you see when it's time for ovulation, it's like the fallopian tube moves a little closer. You know, you could look for that on YouTube and these things, and so that it can trap the egg, all of that stuff. But it's not that they're like this all the time.
Okay.
But they're two different structures,
Okay.
but they are closely and intimately connected by other tissue.
So I promise I was going somewhere with this.
Yes. Wait. So the
okay.
body, your body is the uterus.
Okay.
Right? And let's say up to the knees. Okay? Which is where your cervix begins, and then the cervix goes down. So the cervix has an opening that goes up, all right, into the inside of the uterus, and inside the uterus is basically inside of you. So that's like a picture to show you how you're set
so
up.
Yeah. Okay.
And body, cervix. Yeah, that's how I think I've been able to explain it a little.
Yes.
And it seems to work.
Yeah.
It seems to work.
Definitely painted a picture.
Yes. If I say pop-up, people think of juice and
okay.
eating and stuff. So
okay.
Yeah.
So it sort of answers the question.
Oh, okay.
When you remove the uterus, the ovaries aren't just in there flapping around.
No, they have ligaments. They have ligaments.
So they're connected.
They're connected.
Great.
They have ligaments. They're connected to the rest of the body, to the side wall. You have your, I was going to say infundibulopelvic ligaments. Okay, you have ligaments. Don't worry about the names. But you have ligaments that connect your ovary to your side wall, to the side of your body, so to speak, on the inside. So they're not just flapping around.
Oh, that's why sometimes when you ovulate, you can feel the pain in your side.
Maybe.
Because it's attached.
Maybe, assuming that is the pain that you're referring to. But yes, we do have a pain. That pain actually has a name, and we're going way into another bunny trail. But that pain actually has a name, which is Mittelschmerz. I've always found it such a funny name. I have to remember it. Mittelschmerz. Yes.
There we go.
It's been named because of how common it is, and the fact that people wanted to find out what is this thing, and somebody say, you know what, let's just call it that. And every time we say that, people know exactly what we're talking about.
Okay. All right. Yeah. So my brain went there when we spoke about the hysterectomy, and I just wanted to make sure that the ovaries weren't just
they're not rolling around in the abdomen, and God forbid. No.
Good. All right.
There is wisdom in this. So you have connections on one side, and you have connections on the other side.
On the other side. Yeah. Great. So we've completed the bit on surgery where you can go either open right up and go in and take it out, or we can do it laser or laparoscopic. Okay.
As well. Yeah. Then there's another type of treatment that it's not exactly surgical, but it is interventional. It is somewhat invasive as well, but yet not as invasive as, let's say, surgery. Okay. It's done by interventional radiologists generally, which is uterine artery embolism. So what happens is that, remember we said that these fibroids, they love the blood supply. When they don't have enough blood, they've gotten so big, they get upset, they degenerate, that sort of thing. Just my way of putting it to layman's language. So what is done with UAE is that it's also called uterine fibroid embolization as well too. Okay. So the blood supply is targeted there. So you go in, and what they do is that they essentially close off the blood supply totally so that this thing cannot grow. And then what you find is that over time, it actually shrinks. I'm not sure if that's done in the Caribbean though. Okay. I think there was a center in Trinidad at one point that was doing it, but I'm not sure if they still do. But definitely the US and the UK, they do UAE. They do. So that's interventional. Then you have your medical ones, hormonal treatments, non-hormonal treatments, basically the things that don't involve cutting or intervening physically into the body. Okay. So you may have injections, you may have pills, you may have even dietary changes are considered part of your treatment, as well as the ability to, increase your exercise, all of that. That lifestyle changes would probably encompass all of that. So there are actually hormonal treatments for fibroids as well, which do not usually include estrogen, but high progesterone, which is sort of the antagonist, if you want to put like you have a seesaw, for hormones,
Mhm.
right? So when one is up, the other one's down, normal circumstances. I say normal because, of course, there's a cycle,
Right.
in the body.
Yes.
But if you want the estrogen to go down, then you put up your progesterone, in essence. Okay, it's antagonistic. So there are some high progesterone treatments that can be used to actually cause your fibroids to shrink, or at least not have you have all that bleeding and other symptoms that you would have, because the treatment here is mainly dealing with your symptoms. All right. I just remember there's actually another semi-interventional one, which was the IUD. Yes. So we have not the usual copper IUDs.
Okay.
The copper IUD, unfortunately, can increase your bleeding sometimes. So that one doesn't really do anything for fibroids, and it doesn't really help your symptoms. But the IUD that has hormones in it.
So this is not, I'll just say, this is not a plug, it's not an ad. we see the commercials and we see that. So is this like the Mirena?
Yes, it's like the Mirena.
Okay.
It's like the Mirena. I think, and well, I'll use FDA. I think the FDA has actually okayed maybe about 3 different types.
Okay.
I think it's Mirena, Skylar, and okay, no ads, no affiliation,
none. But we see the commercials.
Just letting you know, the Mirena is one of them, and it's actually one of the ways in which you can have a lot of improvement in terms of the bleeding profile when you have fibroids. The only thing with that is, if you have your cavity very deformed because of the fibroids, then no, it's probably not the best thing. But if you still have, once you can actually get the IUD in safely and there are no complications with that, then it would be useful for you.
Right, because we said if it's lower down and depending on the location.
Yeah, location and all of that would be a factor, yes. But it actually can help. It actually is one of the ways in which we can treat the bleeding aspect of fibroids. And then, of course, the pills and so on. Okay, so there are the hormonal injections to deal with the bleeding as well, like your Depo and so on, can help with the bleeding. And of course, as we said, high progesterone, long enough time, then you might actually see some shrinkage, right? Then there are other injections that are also against estrogen, so to speak, or against certain receptors that would, and I don't want to go too much into that, but they are against the hyper production or existence of estrogen in the body. They put your body in a sort of a menopausal state, if you wish. All right. And those injections, for example, it will be like every 3 months or every 6 months, depending on the dose. And those would shrink the fibroids for a while, but unfortunately, it's not permanent. Yeah. So let's say, for example, you are planning to have surgery and you're trying to have surgery in a safer way or less complications, less bleeding. You may put a patient on those injections for a bit and then have the surgery after. There are some people who they have so much relief after going in the injections, they sometimes change their mind from surgery. But after a while,
can they do it long term?
It comes back. There are other effects because of the menopausal state that it causes. Yeah, you can have, I think it's bone loss and a few other things as being side effects. Yeah, can't remember all of them right now, actually. But yeah, those are the ideas. That's the idea. So apart from those, then you also have, there's some oral ones that are new. Yes. And unfortunately, we don't have access to them yet. But you see, I think I've been scarred by one of the ones that existed before, which had such good promise. It actually shrank your fibroids and they stayed shrunk, unlike a lot of the other treatments. But unfortunately, after a number of years, it was shown that it also caused liver injury as well, too. So, or toxicity, something to that effect. And it was pulled off the market in our part of the world. So yeah, so I'm scarred in a way. Why I say that is because I'm still not, even though I'm excited about the new set of drugs, and there are a lot of people who are very excited about it, I'm still kind of saying, okay, let me see if this is going to disappoint me as well. But they have shown, a bit cautious,
excited but cautious.
Yes, a bit cautious, but excited because they also have been shown to have great effect in terms of shrinking fibroids and so on. Yeah, but those are fairly new.
Okay.
And anywhere you go, you will read the newest, form of oral treatment for fibroids. Yeah, and the thing with those is that they're tablets. They're not injections. They're not painful to take.
As in daily? You take them?
Actually, I'm not sure exactly
No?
what the dose, how you would take it, because they're also different ones. They're about 2 or 3 different ones, and you do in some cases have to take them in conjunction with hormonal treatments.
Okay.
But yeah, I haven't actually used them as yet. So
okay, I asked because personally, if I was to choose between a daily tablet and a monthly injection, or even a weekly injection, I would choose the injection.
Yeah, I
know. I'm not fearful of them.
Remember,
we know
I know this. However,
just like
yes, I know this.
Yes,
but
it's
most people prefer to take a tablet.
I think we've established not most people here.
That's okay. Everyone is expected to be different and special, so that's fine.
There we go.
But yes, that is why we have different forms of treatment too.
Yeah.
Because no one solution is the best for everyone. So you must have options.
Yeah.
You must have options.
Great.
Trying to remember if there's anything else I'm forgetting. Yeah.
But you'll be back. If there's anything that you may have forgotten, certainly you'll be back.
I mean, like send it to you by text or something. Anyway, yes. Go ahead. Sorry.
In terms of, I think one of the things that concerns persons, and I know we started by saying that fibroids are growths, they are tumors, but they're non-cancerous.
Yes.
Is there any possibility for them to become cancerous at any point?
So what I will say is that there is always the possibility of a misdiagnosis that can exist, where something looks like a fibroid and it really wasn't, which is why we do testing, which is why we actually do follow-up, serial ultrasounds or whatever else, depending on what we're seeing. So that exists. There are also cancer markers that can assist a bit as well too, in terms of differentiating the two.
Okay.
Because there are uterine cancers called sarcomas that also grow within that layer of the uterus. But they tend to be a bit more aggressive than fibroids usually. So when we see, for example, aggressive growth, usually you'd more think, okay, maybe something else is going on, which is why I said before, if you're in a menopausal time and you have increased growth and you're supposed to be hyperestrogenic, then it may, you need to check it out. So yeah, that possibility exists. But then because of the frequency, we're looking at maybe 1% out of 100 that may actually be that way. So it's not as frequent as fibroids, but the issue is when you do have the diagnosis, just make sure the diagnosis is correct.
Okay.
And usually fibroids respond to treatment. The sarcoma would not respond the way the fibroid would.
Okay. So fibroids don't become cancerous.
No.
It would have to be
There was a
sarcoma?
time when they said less than 1% could become. But then you kind of wonder if that 1% was actually just a misdiagnosis on its own as well too. So I haven't thankfully seen any cases where we've mixed that up with someone, especially who's been followed. There are people who may have thought it was that and then come and find out that it's not. But yeah, but it's not frequent. If that misdiagnosis or that even, let's say there was a possibility of it becoming, it's definitely not something that would be frequent. Okay, but they're not tumors. They don't become tumors. It's what you would read on everywhere. Okay, but I say that about the misdiagnosis because there are some cases where a sarcoma can look like a fibroid when it's starting out. Okay. So you just follow up. Don't set it and forget it. Follow up.
Good. I think that's really good advice as we wrap up. If there's anything else that you would like to leave with our viewers as it relates to fibroids, or just in general, No.
in general.
In general, as your OB, get your annual checks. No, we've said that
Yes,
before.
yes, definitely. Get your checks. I'm going to put out, do your pap smears as well. Very important. I'm also going to say, if you're not sure, don't assume it's normal.
Mm.
Okay? If you're not sure, don't assume it's normal. It's better to be told by someone who checks it's normal than to assume it's normal and then 3-4 years down the road find out it wasn't. So yeah, let us all be mindful of our own health and our own bodies, because nobody knows your body better than you do. At least that's how it should be.
All right. Great. Dr. John, thank you so much
You are
for
welcome.
joining me here on We Need to Talk. I do hope that this is not the last time you're here. I'm just putting that out there for you. I do hope that we can have you
Promises,
back.
promises.
All right.
Yeah, but thank you for having me. I actually enjoyed being here. I like the fact that it's a conversation. That's the thing. That's the thing. And and that's one other thing. Talk to other people as well too about what you're experiencing, and then you'll realize sometimes what actually is normal and what isn't.
What isn't? Yeah, and that's again, I think I say it almost every show. This is why we do this. This is why I do this, because conversations are important.
Yes.
If we keep things to ourselves, we just never know what's going on. You never know
True.
who is the next person that you can help simply by having a conversation. So thank you for joining us here on We Need to Talk. The conversations continue. We had a really excellent conversation today about fibroids. If you have concerns, if you have any symptoms, do be sure to go and get checked out. And again, like, follow, subscribe on all of our social media platforms, and join us back here again next week for another episode, because we need to talk.